from patients and from healthcare providers is, isn't it safer to have a pap test every year? No, we moved to screening every 3 years. It's been almost a decade or more since that happened. But a lot of patients still want to get a pap test every year because that's what they're used to. And a lot of providers also think that it would be better to get a pap test every year. And actually, screening every year is not safer than having a pap test every 3 years. And that's because we're balancing the risk of developing cervical cancer versus the harms that can be done by unnecessary tests for false positive screening. So having a pap test every 3 years does not increase the risk of developing cervical cancer. It takes a very long time for a human papillomavirus to cause changes on the cervix that can lead to a cancer. And that's the reason why cervical screening is so effective, because we have a long interval between HPV infection and cancer to be able to detect those changes and intervene. If we do pap tests every year, pap tests are a very sensitive test, meaning they pick up things very quickly and easily. And so you get a lot of false positives. So the pap test looks abnormal when really it's normal. And in order to sort that out, patients have to go either have a repeat pap test or go to colposcopy, potentially have biopsies, get treatments that are really unnecessary. And so we found when we look at population level data that screening every 3 years is an adequate interval to detect changes on the cervix and minimize the risk of developing cervical cancer, while at the same time not over treating people or unnecessarily treating people. Another question that patients have a lot is that they're concerned that by getting a pap test, we're looking for cancer. And that's because we, as healthcare providers and the Ontario Cervical Screening Program for a long time, always said that we're screening for cervical cancer. And pap tests absolutely are not screening for cervical cancer. Pap tests look for pre-cancer changes on the cervix that could lead to becoming a cancer of the cervix. And so what we're detecting on cervical screening is pre-cancer changes that are very treatable. And we know if we treat it, we can prevent women from developing cancer. So it's different from colon cancer screening for breast screening, where you are detecting early cancers. With cervical screening, we're detecting pre-cancer changes. These changes typically have no symptoms whatsoever, as opposed to someone who has cervical cancer. They oftentimes have irregular bleeding, abnormal discharge, foul-smelling odor. So we actually consider detecting cervical cancer on a pap test as a failure of screening, because that individual should have had a pap test or HPV test prior to developing cancer, because we know it takes 10 years. So typically that means they haven't had routine screening. And we know that most cancers are picked up in people who haven't had a pap test in the last 10 years. Why do I get a letter from Cancer Care Ontario after my pap test? This kind of goes hand in hand with the last question, that a lot of people get freaked out. Like, if it's not a cancer, then why am I getting a letter from Cancer Care Ontario? And it's because the cervical screening is part of the Ontario Cervical Screening Program, which is part of Cancer Care Ontario. And it's an organized screening program. And the hallmarks of organized screening programs are that you get reminder letters to remind you when you're due for cervical screening. And then you get follow-up letters to let you know the results of your cervical screening. And these two mechanisms are in place to ensure that people get screened at an adequate interval, because it is harder to remember to get screened every 3 years than it is once a year. And also a reminder for patients about the results, so they know that they're normal, and it will indicate on the letter that they should be seen in follow-up in 3 years' time, or if the result is abnormal, the notification also includes language around follow-up for the patient. So as I mentioned, it's an organized screening program. You get reminders when you're due and notification about results. And the other organized screening programs are the Ontario Breast Screening Program, the Colon Cancer Check Program, and the new Ontario Lung Screening Program. So another common question that I get is, what is HPV? So HPV is a virus. It's human papillomavirus. There are two types. There are low-risk types of HPV. These cause anogenital warts. Typically, those are associated with HPV type 16 and 11, which cause 90% of genital warts, and some types of low-grade cervical dysplasia. So oftentimes we see this in women who have L-cell or ascus pap tests that are persistently L-cell or ascus and never progress. Those are likely due to low-risk types of HPV. These low-risk types do not cause cervical cancer. So they will always remain low-grade changes, either in the form of genital warts or low-grade or ascus pap tests. Then there are a group of HPV strains that do cause cervical cancer, and we call those high-risk HPV or HR-HPV. So you might see that on requisitions or on communication back from the colposcopy clinic. And this high-risk HPV can cause high-grade cervical dysplasia and cervical cancer. And so when you get that back on a pap test, that could be ASK-H. So abnormal squamous cells of undetermined significance cannot rule out high-grade changes. Could be a high-grade pap test, which is denoted as HSIL, or any of the glandular lesions. So adenocarcinoma in situ, abnormal glandular cells, or abnormal glandular cells of undetermined significance. These are the two highest risk types are HPV 16 and 18, and those two types cause 70% of cervical cancers. HPV 18 in particular is responsible for these glandular lesions. So if you have a pap test that says AIS or AGC, typically that person has HPV 18. HPV 16 is responsible for most other high-grade squamous lesions of the cervix. There are another 5 types of HPV that are associated with the remaining 20% of cervical cancers. And when you do an HPV test for a patient, so say your patient has an ascus pap test and they choose to do HPV screening, they will tell you if they have either HPV 16 or 18 or another high risk type. And that usually includes at least these 5, but it could be include other types. So all of these high-risk types of HPV are responsible for the development of cervical cancer. So it is a virus and it is a sexually transmitted infection. And that comes to the next most common question, is HPV a sexually transmitted infection? And the answer to that is yes. Human papillomavirus is a sexually transmitted infection. It's treated through any type of sexual touch. It doesn't matter if it's with the genital organs or if it's with hand, skin, mouth, it doesn't matter. Any type of sexual touch and you get HPV. It's very, very, very communicable. You can get infection with multiple types. If you have one type of HPV, it doesn't protect against other types of HPV. There are high rates of infection in women and men under the age of 25 and in men actually of all ages. The lifetime risk of infection is 75%, and I'm going to talk about that in the next slide. So really, it's a viral infection that we acquire when we start having sexual contact with people, regardless of whether or not that's sexual intercourse. And that's one of the reasons why vaccination is so important, and vaccination at an early age, because oftentimes teens will have sexual encounters, maybe not sexual intercourse, and that's still a risk factor for developing HPV infection. HPV can cause cancers of the head and neck, the female lower genital tract, penis, and anus as well. So how do you get rid of HPV? There are 2 ways to manage human papillomavirus. The first is getting vaccinated, and the second is to have screening and follow up if your screening test is abnormal. So I'll talk about vaccination first. So HPV vaccination is approved for girls and women aged 9 to 45 and boys and men aged 9 to 26 in Canada. And however, you may see patients or clients that you have receiving the HPV vaccine outside of these parameters in the colposcopy clinic. So when we're using a medication in an off-label way in this for prevention of progression of cervical lesions or cervical cancer, we'll have a discussion with them about the validity of that based on the current evidence. But right now in Canada, the HPV vaccine is approved for girls and women aged 9 to 45 and boys and men aged 9 to 26. And I'm just going to jump back to a previous slide. So the strains of HPV that are included in the vaccine for the high risk types, it's 16 and 18, plus these additional 5 types. The vaccine also includes 6 and 11. So you get protection for 90% of genital warts, as well as 90% of cervical cancers. The vaccine is available in a school-based program for boys and girls in grade 7 and 8. The important thing to know, it's an opt-in program, so it's nice to have that conversation with parents or guardians about HPV vaccination when their children are approaching that age, that they need to sign a consent for their child to get the HPV vaccine. And that's just because of the when it was introduced in a gendered fashion. There was a lot of anxiety around the indication for HPV that we're assuming that children are having sex. And as a result, it was made as an opt-in program. We know, however, though, we give the hepatitis B vaccine at exactly the same age group for exactly the same indication, and it's not an opt-in program, but it is also can be transmitted sexually, and that's why we give that vaccine at that time. So it's really, and you can talk about that with parents and caregivers and guardians to sort of normalize the HPV vaccine. There is a catch-up program through public health up to age 18. And there's also a special public health-based program for men who have sex with men up to the age of 26 for vaccination, because this group has the highest risk of HPV-related comorbidities. So we know we can prevent HPV by vaccinating. And in countries like Australia, where the vaccine has been available for over 20 years, they've almost completely eliminated genital warts in women under the age of 30. And we'll start to see the population effect of the prevention of precancerous lesions on the cervix in the next 5 to 10 years. Another question is that we commonly get is, what happens if I have an abnormal pap test? So if you have an abnormal pap test, your primary care provider may do one of two things: either repeat the pap test in 1 year if the original pap test showed low-grade changes. So if the original pap test shows low-grade changes or ascus, then we repeat that pap test in 1 year. We don't repeat in 6 months anymore. Pap tests repeated in 6 months are going to be rejected. This is a quality indicator for Cancer Care Ontario and the Ontario Cervical Screening Program. And so we cannot accept repeat pap tests in 6 months. We'll send a note back saying, please repeat this a year from the original pap test. Or if the original pap test was high grade, or you had 2 low grade pap tests, then you'll need to go to colposcopy to take a better look at the cervix and treat the HPV infection that might be there. So if you have 2 low grade pap tests 1 year apart, or if you have a high grade pap test, which could be ASK-H, H-cell, adenocarcinoma in situ, abnormal glandular cells, or abnormal glandular cells of undetermined significance, those people need to go straight to colposcopy, and they will be seen with the high grade PAPs within 4 weeks and the low grade PAPs within 12 weeks. When a patient goes to colposcopy, we'll do a more detailed exam of the cervix. So it'll be very similar to a pap test in that we place a speculum in the vagina. The difference being is that we put a vinegar solution on the cervix. If there are abnormal cells there, they turn white, and we use a microscope to look at those cells. If there are changes that look concerning for precancer changes on the cervix, then we may do a biopsy of the cervix so we have a better understanding of what's happening. So that is the basic colposcopy examination, and it takes about 5 to 7 minutes. Another question that we get is, do I have to tell my partner that I have HPV? Because as we said, it is a sexually transmitted infection. And as we talked about before, almost everyone gets HPV in their lifetime. The lifetime risk for HPV is about 75%. So it is important to have open conversations about sexual health with your partner or partners. So I always encourage patients to do that. It's not um, it's not absolutely essential that they tell their partner about HPV because everybody gets it if they've had any sexual contact. The 75% lifetime risk comes about because people who have a cervix are able to clear HPV infections up until about the age of 30 without having any treatment to the cervix. This is particularly the case in people with a cervix up to the age of 25, and that's why we don't recommend starting cervical screening until the age of 25, because most infections can be cleared spontaneously, and that clearance goes up until about the age of 30. People who are born with a penis, however, can never get rid of HPV. So if a man has an HPV infection, they have it for the rest of their life. Whereas women can get rid of it up until about the age of 30, which is why we have that 75% lifetime risk. And that also includes some people who have no sexual contact in their life. What's the difference between a pap test and an HPV test? This is going to be a really important question coming up. I have patients ask me this question in the colposcopy clinic all the time because I routinely do HPV testing in that setting as a part of triage when someone comes into colposcopy and also to triage patients when they leave colposcopy. But the Ontario Cervical Screening Program is going to be moving towards primary HPV screening. So that means no more pap screening. The first test that a patient will get when they're getting their cervix screened is an HPV test. And only if that's positive will they get a reflex pap test. So the difference, I'm going to go through the differences between an HPV test and a pap test and why an HPV test is a better test for cervical screening than a pap test. So a pap test is an indirect test of HPV infection. So what that means is a pap test is looking for cells that have been infected with HPV, and they can have differences in the way those cells look based on that HPV infection when we look at them under a microscope and stain them with pathology stains. Sometimes, though, it can be difficult to determine if a cell has been infected by HPV or if there's just inflammation. Those two things can look very similar on a pap test. The other condition or stage in life that can be a little bit confusing to discern between HPV infection and normal is with people who are in menopause. So oftentimes changes in the cells in the lower genital tract that occur during menopause can sometimes look like HPV infection under a microscope, which is why we oftentimes see ASCUS pap tests in women after menopause. Because we're not directly looking at HPV, we're looking at the cell response to HPV infection in a pap test. Whereas the HPV test directly tests for the presence of high-risk strains of HPV by looking at HPV DNA or RNA in the vaginal and cervical fluid. So the HPV test is very, very specific for the presence of HPV, whereas the pap test is very sensitive to detecting changes in the cells in the cervix, which means you have many, many more false positive pap tests than you do HPV tests. So as I mentioned with the pap test, it's looking for changes in the cells that could represent HPV infection, but don't always. The HPV test for the presence of HPV in the cervical and vaginal fluid. A pap test assesses risk by looking at those changes in the cells and classifying them as either low-grade changes or high-grade changes, or if the cells look a little bit funny but don't classically look like low-grade changes or high-grade changes, then we say that they're abnormal squamous cells of undetermined significance. If there are cells there that look like they're from a glandular cell line rather than the squamous cell line, we get abnormal glandular cells. So it classifies by cell type. squamous or glandular, and then by high grade or low grade, or a catch-all, it looks funny, but we don't know what it is, and that's ascus. An HPV test stratifies by identifying the presence of high-risk HPV versus non-high risk HPV. And within that group of high-risk HPV, it will tell you about type 16 and type 18, which are the two most common causes of cervical cancer versus other high-risk types, which can also cause cervical cancer. So the report will say either negative for high-risk HPV, positive or negative for type 16, positive or negative for type 18, positive or negative for high-risk HPV. The PAP test has, it should say, high sensitivity and low specificity, whereas the HPV test has both high sensitivity and high specificity, making it a much better test. If there's a positive PAP test, we need to see the patient in colposcopy and take a biopsy of the cervix in order to diagnose if there truly are changes there, versus an HPV test, which requires reflex screening with a pap test or a biopsy to see if there are actually changes on the cervix. And that's because even if you have HPV in the cervix, it doesn't mean that that HPV has caused changes on the cervix that could lead to cervical cancer. The immune system might be able to mediate that HPV in the cervical and vaginal fluid and prevent dysplastic changes from occurring, in which case you can have a positive high-risk HPV strain and a normal PAP, and those people need to be followed annually with screening. Or you can have HPV and you can have cervical dysplasia, and you would pick that up either on a pap test or a biopsy. So going forward, when we move to HPV testing as the primary screen, you'll get a report back either saying that the patient does not have high-risk HPV, and then it will tell you if they have HPV 16, HPV 18, or high-risk HPV. If they have any of those high-risk types, they will have a reflex pap test. So you don't have to order it. It will be done from that same sample. If that reflex pap test is normal, then that person may need to be seen in the colposcopy clinic or may just need annual screening. If that reflex pap test is abnormal, then they'll need referral to colposcopy. So the goal from the World Health Organization is to eliminate cervical cancer by 2030. And as part of those goals from the World Health Organization, we want to make sure that 90% of girls and people with a cervix are vaccinated by the age of 15, that 70% of people with a cervix are screened for cervical cancer between the age of 35 and 45. And the third pillar of the elimination strategy is 90% of women who have positive cervical screening should receive treatment. In terms of how we're doing in Northwestern Ontario, in the Thunder Bay district, we're at 47% vaccination. Sorry, Kenora district, we're at 47% vaccination, and Thunder Bay district, 51% vaccination. So we still have a long way to go. In both health units, our screening rate's about 52%. And in terms of people who have a positive cervical screen and who are seen in colposcopy, that number is only about 53%. We know in the west part of our region that some of those individuals are receiving treatment in Manitoba, which is much closer. Unfortunately, we're not able to capture those stats, so that number isn't an accurate reflection of the true number of women who are treated. So we still have a long way to go in our goals of reaching the elimination of cervical cancer by 2023. So I will take questions.
Thank you, Dr. Jumah. That was highly informative and very easy to understand and go through the presentation. We don't have any questions yet. Okay, here's one. Do we know when the transition will be made to HPV testing?
Yes, so I know that's a question that's been this has been discussed at least for the last 10 years, if not more. And I think the Ontario Cervical Screening Program has gotten a vendor for the HPV test, which was a big part of the issue. So they have said that it will happen within the next year to 18 months. One of the things that has held up rollout is that they've introduced lung screening, and then they also introduced changes to the Ontario breast screening program. So they've had to pull back a little bit on the implementation of HPV testing for cervical screening because a lot of people are feeling quite overwhelmed, both in terms of primary care and cancer centers and in terms of dealing with all of these new patients. So it should be within the next 12 to 18 months.
Thank you. The next question is, do we know when HPV testing will be publicly funded?
So it will be publicly funded once it's implemented as a screening test. So that will come with the introduction of HPV primary screening. The billing rates and things like that for OHIP have been established. So all of that is ready to roll out once the OCSP moves to primary screening with HPV. So right now, I would recommend if patients can afford it and they want to, if they have an ASCUS pap test and they're over the age of 30, they can get HPV testing. Again, it's out of pocket. It's depending where you are, anywhere between $75 and $100 to get that testing. I wouldn't really recommend getting that testing in people under the age of 30 because it's going to come back positive, and it won't really help in terms of determining their management. And in those people, referral to the colposcopy clinic when they meet criteria is much more helpful in terms of their management.
Thank you. There's a follow-up question to the first question about the transition. Can a swab be done at home? Is that correct?
Yes, so that is an excellent question, and thank you for asking because that gives me more ammunition to take back to the Ontario Cervical Screening Program. So as some of you may know, we did have a self-sampling trial here in Northwestern Ontario that is more than a decade ago. We were really at the forefront of HPV primary screening. And other jurisdictions have moved to that. So British Columbia has moved, they moved to HPV primary screening a few years ago, and now they're doing self-screening for HPV. I think Prince Edward Island is moving that way. Everyone is moving that way. The Ontario Cervical Screening Program has dug their heels in the mud and said, we're not doing that. I think there's going to be a much bigger push towards, a national push towards self-sampling from the Gynecologic Oncologists of Canada, from the Society of Canadian Colposcopists, and there are a lot of us who are leads for cervical screening in our regions who are also pushing for self-sampling. But at this time, it will not be part of the rollout of the program. So hopefully we can introduce that at some point because I think it's really important, especially in our population where we have a lot of women who've experienced sexual violence, sexual trauma. That can be a good starting point to get screening initiated, understanding that if they screen positive, they would need follow-up.
Thank you for that. There is a comment that says, thank you for the information, really good presentation. And there's a question about the presentation, whether it'll be emailed or available to watch. It will be available to watch at the link provided in the chat box. However, I can
I'm happy to share it.
Yeah, and also the recording itself, I'm happy to share it to your email as well if you would like that. Okay, the next question. How frequently would individuals need HPV testing?
Great question. So it's a little bit more complicated than the pap screening. So this is going to require like a little bit more education on our part from the Ontario Cervical Screening Program. So the screening interval is going to move to every 5 years if you have a normal HPV test. So if your HPV test is negative for high risk types, then you'll need repeat HPV testing in 5 years. So that's for your average person with a cervix. If you have someone who's immunocompromised, and there's going to be very strict outline of what that means. So definitely it's anyone who's on immunosuppressant medications, but it also includes people with lupus who are at higher risk. It includes people who have HIV, whether or not they're well managed with antiretroviral therapy. They will require HPV screening every 2 to 3 years. Because their immune system may not be as robust at dealing with HPV infection. And then if someone is seen in colposcopy, depending on what their colposcopy findings were and their HPV status at the time of discharge, they may need to be followed every 2, 3, or 5 years as an outpatient, and that may also include cervical pap screening as well. So it's going to be a much more complicated algorithm than the current pap screening algorithm, and that's because it's really based on population-based data that allows us to determine the risk for developing cervical cancer based on the combination of HPV test and pap test. And we have a threshold for which people need to meet in order to be seen in colposcopy or to be discharged from a colposcopy, which makes it much, much more complicated. Right now, we don't have an app for that because in the States, they do have an app. So you can basically punch in your individual patient's characteristics and it'll tell you what the follow-up was. We don't have that, but we will have color-coded red, green, and yellow pathways to guide people on when someone needs to have repeat cervical screening if they're in the average risk category, if they're in the intermediate risk category, or if they're in the high risk category.
Thank you. That's interesting and great to know. The next question is, how is the HPV test done?
So in the way that this is being rolled out in the Ontario Cervical Screening Program, it's basically a pap test. So it's exactly the same as you would do for a pap test. It might be, depending on where you are in the region, it might be a different reagent bottle than what you're used to. There's different brands, so you might need to switch brands once it's rolled out, but basically it's a pap test. And from that test, they'll be able to test for HPV. And if that test comes back positive for HPV, then they'll be able to do a reflex pap test on the same sample. So it's exactly the same as a pap test. You won't need any new equipment. Unfortunately, it's not a swab, but that's because we need to get that reflex cytology.
Okay, thank you. Another comment from Alana. Thank you. From the perspective of a nurse working with Indigenous populations, I know seeking such personal care from non-Indigenous care providers can be intimidating, and I think self-sampling would increase HPV testing rates for our Indigenous women.
Yeah, I absolutely agree. I absolutely agree with that. And I think, I'm a non-Indigenous care provider and I do a lot of pap tests in my general gynecology clinic. And then I also have quite a large colposcopy clinic here at the hospital. And one of the things that I can do, one of the things that I do in my clinic that helps make patients more comfortable is I practice in a trauma-informed way and do a trauma-informed exam. And that has worked really well for me in terms of making patients feel comfortable, letting them know they're in control of the situation. And sometimes, because I practice in this way, sometimes when people come to see me for their initial visit, if they're not comfortable, if they can't follow through on the exam, we stop and I book them back at another time so that they can feel more comfortable with the situation and have less anxiety. And usually when I do that, it really goes a long way in terms of developing that trust with the patient, building that relationship. And then I find that after that, patients are able to do the exam with a lot less difficulty and a lot less stress and anxiety for them. So that's potentially something I could talk about at a future webinar, is sort of strategies to be able to do safe exams for pap tests and cervical screening, STI screening, those sorts of things.
Thank you. Are there any more questions? That is all that we have at the moment in the chat box. Please feel free to ask more here, or you can raise your hand. Maybe we can give a couple minutes for any more questions. Okay, another comment. Would love to learn more about trauma-informed gynecology, like gynecological exams. Thank you.
And I should say, if you have ideas for future webinars or things that you would want to learn more about, please let us know. I'm happy to come up with a presentation that would address that, because it's really important that these meet your needs, because that's why hopefully I'm doing them. So I want to make them as relevant and practical for you as possible. So any ideas, any suggestions, that would be great. If you are participating in Papapalooza next month, thank you very much in advance. And as always, I am here to answer your questions. You can direct them through Krishna after the webinar, or if you want to reach out to me by email, you can as well. Yeah, but I'm always happy to answer questions or troubleshoot if you need.
Yes, I have provided my email address in the chat box below if you'd like to ask any further questions. We do have a survey after this webinar that you can fill out and provide us with more ideas, or you can email me, both work. I think that is all for the questions. We do have a couple comments. Okay, great presentation, Dr. Jumah. Miigwech for your time and knowledge. Thank you for the great presentation.
Thanks. I hope everybody has a few extra minutes to have some lunch.
Yeah, definitely.
Happy Easter if you celebrate.
Thank you everyone for joining. The webinar will be available to you at this website again, just for everybody's reference. And we can send out an email as well. Okay, thank you everyone for your time. Thank you, Dr. Jumah.
Thank you. Bye, everyone.
Bye, have a good day.